One of the known risks of puberty suppression is its effect on bone density. This was addressed by Professor Gary Butler.
The amount of calcium in the bones accelerates during adolescence and into early adult life, so much so that your bones are the strongest by their mid-20s, so that acquisition period in the early years is quite fundamental. Now, if you are taking steps to slow down puberty, the bone mineral content, which is what the amount of calcium in the bones is, carefully monitored, and it's part routine, part and parcel of the assessments there. Now, there is a delay when you instigate puberty blockers in a trans young person of the bone calcium going into the bones. It doesn't actually reduce, it just stands still, it doesn't increase quite as quickly. But what we know that from follow-up studies which have been published from Amsterdam, and what we in the UK are about to publish soon, is that bone calcium content recovers once sex hormones are started.
Let's look at data collected from adolescent patients at the Tavistock's Gender Identity Development Service who were prescribed puberty blockers, gonadotropin-releasing hormone agonists, by Professor Butler. These data were made public following my complaint to the Health Research Authority, so I was able to analyse the bone density of 24 patients after 2 years of puberty suppression, comparing their bone density to the norm for someone of the same age and sex. This comparison is quantified by a Z-score. A negative score indicates bone density below the population norm, and a Z-score that is below a -2 implies a higher risk for osteoporosis. My analysis was published in the Journal of Pediatric Endocrinology and Metabolism. So you can see here are the graphs comparing the bone mineral density, that's the BMD, of patients on puberty blockers, shown by the grey bars, and that's compared to the norm, shown by the blue curve. And you can see that about 1 in 3 patients ended up with hip bone density below -2, and more than 1 in 4 ended up with spine bone density below -2. For the spine, 4 of these teenagers had scores even below -3. In the general population, such extremely low bone density is exceedingly rare, about 1 case in 770. But for adolescents undergoing puberty suppression at the Tavistock, it was 1 patient in 6. Now, it is true, as Professor Butler states, that bone density does begin to catch up once the patient begins taking cross-sex hormones, that is estrogen or testosterone. Before this, however, many adolescents will spend several years with abnormally low bone density. The newspaper, The Times, interviewed 1 patient at the Tavistock Clinic who started GnRHA, puberty blockers, at the age of 12, and this teenager experienced 4 broken bones by the time they were 16 years old. Moreover, the most comprehensive follow-up study from the Amsterdam Gender Clinic reveals that trans women, that is males taking estrogen, still have low bone density in their spine by their late 20s. That's after about 12 years of taking estrogen. So you can see the graph here, taken from this article by the Dutch authors. Puberty suppression reduces the average Z-score from about -0.5 to -1.2, and there is no subsequent recovery. 9 of the patients had a spine Z-score below -2, again, which implies a significant risk of osteoporosis. That's 1/3 of the trans women at the Dutch clinic. In his evidence to the Women's Equality Committee, Professor Butler says that bone density is, quote, carefully monitored. Yet his article published in 2019 suggested, to quote, that yearly DXA scans, and that's the X-ray scans used to measure bone density, may be unnecessary. And again, to quote, yearly DXA scans can be a large expense to service providers. Professor Simona Giordano added this claim in her evidence to the committee.
And just a small point perhaps on this, that there is no case in the literature reported of complaint around loss of mineral density from the cohort of the children treated since the mid-1990s. No report in the literature, no litigation, no complaint gone through clinical authorities from patients.
This statement is false. Swedish public television in 2022 reported 13 complaints to the Karolinska Clinic, that's the clinic in Stockholm, including 3 complaints involving bone density. One example, Leo was given puberty blockers at the age of 11 after 4 years on gonadotropin-releasing hormone agonist, 4 years of puberty suppression, with Leo complaining about constant pain. The clinic first checked this patient's bone density, and Leo was found to have osteoporosis. Cases like Leo's ended puberty suppression for gender dysphoria in Sweden.